this lesson, I'm going to be talking about hyperbilirubinemia and your role in providing care for this patient. So what is hyperbilirubinemia? So it is high bilirubin levels in the blood. And then what is bilirubin? So bilirubin is forms from the liver, and the liver breaks down red blood cells and is excreting them into the feces, and that's what the bilirubin is. So with this, it's a common problem in newborns. Why would that be? So with the newborns, a few things. We didn't have to worry about doing this when they were in utero, right? They didn't have these broken down red blood cells that needed to be excreted when they were in utero. So sometimes they have an immature liver. So immature, that just cannot excrete and get them out fast enough. Okay, so a few reasons for that, either being premature or whatever it may be. So an immature liver. They might also have a lot of bruising from delivery. And bruising will mean broken down red blood cells, right? So with these, then they're going to be having higher bilirubin levels because they have a lot more broken down red blood cells. They might not be feeding great. So that's another reason that bilirubin can get high, because if it is excreted in the stool, in the feces, and they're not feeding enough to help get the bowel moving and get it out of their system, then their bilirubin is also going to be higher. So there's two different classifications. There is going to be pathological and physiological jaundice to understand. So when this bilirubin builds up, they get jaundice. So now we'll look at that. So our pathological versus our physiological. Pathological first. So pathological jaundice, this is going to appear within the first 24 hours. So that's your key number just to remember. So the first 24 hours of life. And it indicates that there is a pathological process going on. So this could mean something, it's just something else other than the normal process. It could be that there's a blood incompatibility problem between mom and baby. So maybe there had been some blood mixture between mom and baby occur, and the bloods don't mix. So then the baby's going to break down those red blood cells that don't belong to it because it's not that baby's blood. It could also be that there is a liver disease problem happening, just a diseased liver or immature liver. It's just not working properly. So this will be our pathological jaundice, and that's going to require further investigation into whatever the problem is so that we can fix it. Our physiological jaundice, this is going to be starting on the second or third day of life. So not as early as that pathological. So this is just a normal process. It's expected as a normal transition from going from placenta doing work to the baby's liver doing the work. So causes of this can be bruising at delivery that occur. Bruising, remember, is those broken down red blood cells, and they build up. So if there's a lot of bruising, then we have a lot of broken down red blood cells that are building up, and it's adding work on that baby's liver to get them out and excreted. It could be prematurity. So that liver is just young and immature and not working 100% yet. And it could be breastfeeding problems. So if they're not getting enough volume, then they're not excreting enough stool and they're not getting the bilirubin out. So our concern for any of the time is going to be jaundice. If it goes untreated, so if the jaundice goes untreated, so this is our high bili. If it stays up and doesn't get treated, then it can get to these dangerous levels and cause something called kernicterus to occur. So kernicterus is brain damage that can occur. And it occurs because of the hyperbilirubinemia. So for our assessment, this newborn is going to be assessed like normal with a head-to-toe assessment, but you will observe jaundice on a patient with hyperbilirubinemia, so yellowing of the skin, and sometimes the sclera, so not just the skin. So the whites of the eyes can turn yellow. Now, the jaundice is going to start usually at the head, and it's going to build, as it builds, the yellow color is only going to spread, and it's going to spread from head to extremities. So they might be to touch. If you put a finger on their face and touch it and release, then you see the yellow there instead of white. And then you'll see that move down to their diaper area. So it just goes from head down into extremities. You need to have good lighting when you assess this so that you can really see the yellow color. If jaundice occurs and that coloring happens within that first 24 hours, remember that's a red flag, but it's pathological. So we need to notify the doctor and draw bilirubin levels to assess that. Once you have your bilirubin level from the lab, you can graph it. So that's how we're going to tell where we are. So it's going to be rated as a few different items when you graph it. So you will see either it's low risk, low intermediate. It could be high intermediate or high risk. And high risk is when we're going to be starting phototherapy. So it is graphed and it goes by hours of life. So you have the hours that they are old and then the Billy number here, and then it's graphed. So, and then they'll have these little zones like this. So this would be our high risk. If you're above this, this would be your high intermediate, and low risk. So when you graph it out, you just come up and see where the number is. And that'll tell us if you need phototherapy started. If we are high risk, that's when we get the phototherapy going. Usually, different labs are going to obviously have some different numbers, but a pathological issue, you might have a Billy that's not quite as high that will get treated. But our standard number, just kind of to keep in mind, is a total bilirubin level of 12 milligrams per deciliter. That is going to be your number usually at day 2 to 3. That is extremely high risk and that we would need phototherapy. And above 15 is going to be a critical number that we would also need phototherapy for, but maybe even looking into a little bit more so as to why it's that high. Okay, our management. So management's going to be frequent feeding, right? If we can get them hydrated, we need to keep them hydrated. But if we can get more in them, more volume, then that baby's going to stool more. And we need that because that's how it's excreted, is through the stool. So the more they eat, the more they excrete. We also would initiate phototherapy for these kids. So once the levels are high enough in that high risk zone. And education is going to be important once these lights are started. So the baby needs to have these protective goggles, as you can see here in this image, to keep over their eyes, to protect their eyes from that light. And so I just wanted you to have that as a little visual. So those goggles protect from the light. It's funny because when you take them off, whenever you are doing your assessment or take them off to draw your bilirubin level, you will literally see yellowing underneath, like little yellow raccoon eyes. And that's a good sign. It means that the bilirubin's coming down everywhere else. And you can just see where the light has not touched, you'll still see the yellowing color. So it's a good sign. The babies hate being under that light, but it's important to educate the parents that it's important for them to stay under the light. So whatever we can do to keep them comfortable, pacifier, every now and then touch them because they have to be unswaddled and under this and only have their diaper on. So it can be quite miserable for them and for the parents. Our concepts are human development because it's if it's pathological, then it's going to be related to their development. Liver metabolism because the liver's working to excrete that bilirubin. And then nutrition because we need the baby well fed and hydrated to help excrete more of the bilirubin. So on to our important facts. So remember these and you have a good grasp of all of this. So hyperbilirubinemia is high Billy levels in the blood. And remember, 12 is our basic number for our total Billy around day 2 to 3, and 15 is going to be our critical. The bilirubin is from broken down red blood cells that are secreted by the liver. So anything, if we have an immature liver, it's going to cause them to not be excreted as quickly. Immature liver jaundice is that yellow color that they get. That's a sign that our bilirubin is high. And then our phototherapy is going to be our treatment to reduce bilirubin. Make sure you check out all the resources attached to this lesson. Review the difference between your physiological jaundice versus your pathological jaundice. Now go out and be your best selves today. And as always, happy nursing.